introductions, I'm sure a few other people will sign on. So thanks again for joining us for our series on the learning health system. For those of you who sort of know about what we've been doing, we've had about 3 other speakers prior to this. And if any of you are interested in those talks, they've been recorded and they're posted on the CORE website. So thanks again for joining. I know many of you are on vacation today. So we appreciate both our presenters and members of the audience who are on vacation but are diehard fans and committed to the learning health system growth. My name is Allison Hall. I'm a co-director of the CORE, and I am really pleased to introduce our panelists for today. What we're going to do today is emphasize one of the initiatives of the CORE, which is what we call the COVID Core, which was formed, I guess, sometime this summer to help researchers engage, develop ideas, get data around the COVID-19 pandemic. And so our first speaker is not a stranger to anybody, Mike Mugavero, professor of medicine in the Department of Medicine, focusing on infectious diseases. He is director of the CORE, and his work focuses mostly on improving outcomes among patients with HIV. Following Mike, we will have Carrie Howell, who is in the Division of Preventive Medicine, and her work focuses on cardiometabolic disease, intervention targets, and social determinants of health. And then we'll have Yulia Khodneva, who's a 3rd-year research and clinical fellow in general internal medicine in the Division of Preventive Medicine, and she's interested in cardiovascular, epi, and health promotion activities for individuals living with chronic health conditions. And then finally, Katherine Meese, who's an assistant professor in the Department of Health Services Administration, and she is also director of wellness research in the UAB Medicine Office of Wellness. I hope I got that right, Katherine. And she is interested mostly in employee well-being and burnout. And so you'll hear from all of these panelists today Mike will sort of start off by describing the CORE's COVID Core initiative. And then the other 3 panelists, Carrie, Yulia, and Katherine, will discuss some of their work that comes out of our COVID Core initiative. So Mike, it's all yours. Take it away. You're first up.
Great, thank you, Allison. Can everyone see my slides okay? Great, thank you. So thanks so much for the opportunity to present today on behalf of the COVID Core. It takes a village. So in advance, I will try to recognize and acknowledge many people who made this possible, but please accept my apologies in advance if I miss folks. It's been such a journey with so many key people involved. So I apologize if I inadvertently don't recognize everyone who's been instrumental to the success of this initiative. I wanted to point out, if folks haven't found Bmi Tracker, I think it's just an amazing website by a programmer up in the Huntsville area. This is from Friday, the total number of COVID cases in Alabama. It's very small, but 66,000 diagnosed cases in Jefferson County, nearly 20,000 in Shelby, down south, 27,500 in the kind of Mobile area. So just amazing how much, and I think I bring this up, just the power of Bmi Tracker, taking these public health data, making them publicly available, really captured the attention of the general public and how important that is in getting attention around our public health messaging and information, and still going strong with vaccine information. So I go back to a year ago, and Dr. Emily Levitan, Becky Ramey, and myself were invited to present at a Works in Progress about this initiative, the COVID Core, Collaborative Outcomes Research Enterprise. It was last April, so about a month from now, and we talked about developing a prospective cohort study in real time, on the fly, and on a dime. So shortly after COVID hit Alabama, Emily, Becky, and I got together and kind of started brainstorming about an opportunity to study the lived experience from an outcomes perspective of persons diagnosed living with COVID in Alabama. And really from the outset had 2 major areas of focus. One was to think about doing secondary analyses of existing data, be it health system, public health, otherwise, but how do we study the real lived experiences of folks seeking testing and other health services for COVID disease from an outcomes perspective. Second was thinking about developing a long-term longitudinal cohort. So among survivors of COVID, studying longer term and their outcomes. And again, I think the key thing was on a dime. So there weren't resources for this. So we set out to do this thinking this is important, this is good work, could we leverage goodwill, could we leverage other resources? And almost a full year later, Emily is co-leading an MPI study with Gina Marazzo as well as Nathan Erdman, partnering with the Enterprise Protocol to do a longitudinal study through the NIH. So the idea, sometimes serendipity, you have a good idea, you set the roots, you find good partners, and later on the funding opportunities come. So one kind of take home was sometimes when you see opportunity, you chase it, even if you don't have resources, and you find good partners that share interests and try to build things together. So from the outset, this was kind of the purpose of the COVID core. We wanted to engage a collaborative working group to coordinate, collate, facilitate the rigorous and expeditious, that was challenging, completion of COVID-19 health services outcomes, pop health studies by interdisciplinary teams addressing pressing questions germane to individual communities, populations we serve in our city, county, state, Deep South region. And really when we came together and formed a group of a planning committee, some major functions were to think about being a collation or clearinghouse of databases. A lot of folks were developing their own COVID databases. The idea is if we could help combine them or direct people to these databases, they'll get used and be more efficient, more effective. Developing or identifying specific phenotypes, working very closely with the CCTS, Informatics Institute, HSIS to think about phenotypes and people under investigation, ICU, other settings, developing a process for concept proposals to get reviewed, to help build and form teams. So part of the goal with us in the core is can we connect, can we build community, can we bring folks together, to have database informatics liaison to help make study-specific data sets. We'll share more about that. Working really closely with Dave Redden and the Bird, having feedback on design, analysis, interpretation as projects were coming up. And also to explore collaborative opportunities across the CCTS partner network. And with Bob Kimberly and Jennifer Croker's, partnership and relationships, that grant I mentioned for the long-term cohort that Emily is co-leading includes South Alabama and LSU. So a lot of these goals that were set a year ago have come to fruition, many others in development. I'm going to focus the rest of the talk really on the secondary outcomes of health system data, but just to say incredible effort and partnerships to make that long-term COVID cohort application go in, and fingers crossed we get funding to do some really important work to study long COVID and the impacts in our region. So when we started off, we formed these programmatic working groups. So we have to have a platform. We have to build a platform to do this kind of research. And we had 4 big groups. So one was health system data, James Willig, reported outcome, Faith Fletcher and Allison Hall.
Hey, Mike, I think your internet's going in and out. I don't know what you can do. So I guess keep plugging away. Or maybe take your picture off. I don't know if that'll, your video off.
Let me stop sharing my video. Okay. Is that better, Allison?
A little, yeah, a little. Okay. I think it's okay, yeah.
Okay, yeah. So I apologize. Looking beyond the health system at community and public health data with Irf Asif and Monica Aswani, and then Emily and I were going to help co-lead a research coordinating committee. We then realized beyond building a platform, we needed science to drive the work we were going to do. And so started off with 3 different scientific working groups. So there was a health disparities group with the co-leaders shown, neurocognition, and critical care. But starting out with this Works in Progress seminar series, we said anyone that wants to form a working group is welcome. And we were looking to identify leaders of groups that could engage others to join them and think about what is the science that and the important questions within certain different thematic areas. And so from that, 4 different working groups emerged. So not de novo, but over time, some of these folks came to that Works in Progress back in April, including Farhat Zenegal and Ben O'Diden, who joined with Eric Ford to form a financial and operational implications group, Pat Patrician, patient safety and quality, Lisa Norian and Gabrielle Rock about comorbidities, and then healthcare worker well-being and satisfaction led by Greer, Crystal, and Dr. Katherine Meese, who we'll hear from later. So the idea of we'll build a platform, we'll get it started, but want to be very kind of bi-directional that as good ideas emerge and there's sufficient critical mass, we'll support these scientific working groups to come together, ask questions, and conduct collaborative science around COVID. So this beyond the platform, the second important thing was developing a process and a gateway process, and really important to recognize this took a village, not just the core, but HSIS, CCTS, Informatics Institute, RISC, which is the Research Informatics Service Center, and CCTS BIRD. Need to acknowledge Aliyah Tuniger, who both prepared this slide, but has been instrumental behind the scenes making this gateway process work. She has really been the glue and the driver of the success of this. But the idea was, as someone had a concept proposal or a study idea about doing an analysis for COVID, they would come first through a scientific gateway. And they were all on Zoom Wednesday afternoons, 3:35. And someone would come with their team and share their concept proposal. And on that call, we would have someone from the enterprise data warehouse team, someone from the risk informatics team, someone from the core who had outcomes expertise in research, and someone from CCTS expertise in study design and analytics. So we would come through, use that concept as a guide, and give very rigorous feedback. So the EDW and risk IT team were thinking about the data and what data elements would be needed to study. Do they exist? Where do they exist? Simultaneously, conversations with the outcomes research and BIRD folks about what is the design? Does it make sense? Do you have the right data elements? Do you have the right confounder and control variables? And a lot of kind of crosstalk between the data and research folks that enrich those conversations. And I think our panelists will speak to their experiences in going through that gateway. After that first gateway, figured out whether it was non-human subjects or there was an Irb approval, followed by a data gateway meeting. So now your core and CCTS BIRD folks dropped out, and it was the enterprise data warehouse and risk IT team really drilling down, saying, you vetted your question, you vetted your study, how are we going to generate a data set for you? And really going through very specific details, dates, definitions, and whatnot, to then lead to first extraction of the data set out of our health system and I2B2, and then a transformation step, taking those variables and putting them together so that an analysis-ready data set get delivered to that investigator. So I've done nearly 20 of these gateways in the first year. I think a very good process, a lot of lessons learned along the way. Again, to point out, this was all on borrowed time. So all these folks had full-time jobs, other projects before COVID, with COVID, and really it was the generosity of a number of folks dedicating their time to this important shared goal and vision to make this happen. And I think we've had some good successes and some good lessons learned. So I think one of the aha moments for me was this idea of the distinction and the importance of integrating data extraction and data transformation. And incredible efforts by our colleagues in HSIS, CCTS Informatics Institute in taking the raw materials out of our electronic health record and putting them into I2B2, a more manageable data warehouse. And many folks can go do self-service, get the variables they need, the data they need out of I2B2, and that's great. But for a number of other investigators, there was this extra step of data transformation, having another set of data analysts help and say, from those raw materials, can you combine these diagnostic and procedural and laboratory and medication codes to equal these composite variables that will go into my analyses and into my models and my tables and my results in my scholarship. So the idea of the partnership between incredibly talented data analysts, data scientists led by Matt Wyatt, Jeff Gordon, many others doing that data extraction, and then partnering with the risk IT team led by James Willig and Greer Burkholder and Alfredo Guzman and Sunitha Thogarapalli. I mean, so many folks have been involved with this, but integrating the expertise of our data extraction and data transformation teams really proved transformative for this COVID core initiative. So the final thing I really want to talk about, and thanks to Molly Wasco for sharing this network analysis slide, was cultivating an interdisciplinary network of investigators. So this is a network analysis. Each of these circles represents a unique individual who engaged in one of the scientific or programmatic working groups or both. And I won't go into the details, but the different shading from yellow to teal to black to blue indicate different stages from students and postdocs through full professors. And you could see there was just incredible interconnectivity. So across these working groups and programmatic groups, individuals really formed these tight networks, both within these working groups, but then also within these working groups. And I will say, one of the greatest wins for me personally is the number of people who I did not even know were on UAB's campus before this initiative, who I've now met, come to appreciate their work, to collaborate. And a real win has been this platform to bring folks together, many of whom did not even work together, nonetheless know before this initiative. And I think, again, a major win for me in the year of COVID and the many challenges we've endured. So to summarize some highlights, I think some of the lessons learned, it's amazing. It's not even been a year journey, but it's amazing that I think we were able to develop a programmatic and scientific research platform. So I hope I've kind of shared the idea that there was, the platform, but then also a process. So we piloted the scientific and data gateway process. And critically, again, a transformative moment for me, or aha moment for me, was just the power of thinking about the steps of data extraction and transformation and integrating this incredible expertise on campus to do this has been powerful. The cultivation of interdisciplinary, interprofessional community of scholars has been amazing. We still have, in some cases, monthly calls of different work group leaders. People show up, they come on Zoom, turn cameras on, engage. It's really been powerful to see the connectivity around COVID. And I think also a highlight for me was catalyzing scientific collaborations beyond our purpose and function. So we set out to do secondary analyses and to do this long-term cohort, but bringing folks together, not surprisingly, talented, smart folks with different ideas started collaborating on things beyond the scope of the original COVID core. So a major win, I think, for us and added value was, helping to catalyze and bring folks together to do this work beyond our initial stated purpose. So way too many people to thank. These are the early folks who got involved. Many others have gotten on board since then. And then again, want to thank Allison for the opportunity to be part of this today. And also really excited to hear from our three speakers about their experiences and journey working with the COVID core. Thank you.
So thanks, Mike. I'm going to turn it over to Carrie Howell, and while she's pulling up her slides, what I neglected to sort of say is that the way I'll organize the rest of today is we'll let our three remaining panelists speak, and then we'll have some question and answer session at the end of the fourth panelist's presentation. So Carrie Howell, take it away.
Everybody see the slides okay?
Yes, perfect.
Great. Well, thanks, Mike. That was a great introduction, and I echo his sentiment about bringing people together. I was at UAB roughly 4 or 5 months prior to getting involved in this process, so it's been really great for me to learn people, especially since COVID happened and I wasn't able to be, on campus in that traditional way. So I'm going to talk to you a little bit today about a study that I have recently received data from the core, and we are in the data cleaning prep phase. And so the title of this portion is Social Determinants of Health, Insulin Resistance, and Poor COVID-19 Outcomes, a Tale of Two Data Sets. Let's see. Here we go. And I just want to highlight that this is a pilot study that is supported through the UAB OHDRC, which is supported from this NIH grant listed here. So just a little bit of background, obesity and diabetes are associated with COVID-19, and we know that there are well-documented disparities in diabetes and emerging disparities that we're seeing in COVID-19 research. And so the idea is that combining social determinants of health with clinical parameters may provide an avenue to address these disparities, and utilizing the electronic medical record to address disparities is an emerging area of research. So the specific aims for my project are, for the first aim is to assess independent associations between social determinants of health data, both at the individual and neighborhood level, and insulin resistance on COVID-19, poor COVID-19 outcomes. And then for aim 2, we want to use those social determinants of health that we identify in aim 1 and look at the interactions of insulin resistance and social determinants of health on COVID-19 outcomes to identify high-risk subgroups. So this slide is talking about the population. This is what we came to the core and who we wanted. So we wanted patients with a positive COVID-19 PCR in the UAB health system, but we also wanted previous encounters within 3 years in individuals that had clinical data and social determinants of health data available. And then, as Mike explained, this is how we got the data. We went through the COVID-19 core, and as he explained, this is a group at UAB that facilitates the extraction and transformation of electronic medical record data. I think he went through that process very well. And we went through the process that he explained. So we started with the scientific gateway call, which then led to a data extraction meeting, which is very focused on the variables and how we can define that and get that out of the electronic medical record. And then that ends with receiving your data. Here are the variables that we were interested in. So we are interested in COVID-19 outcomes. So we were looking at hospitalization, ICU stay, intubation, and mortality. We're measuring insulin resistance via Tim Garvey's CMDS score, which loads in values, lab values. So we use things like BMI, blood pressure, glucose, triglycerides, and HDL lab values. On the right, we have a table of the social determinant data that we're going to look at for this project. So we have items or measures at the individual level, but we also have neighborhood level variables. The patients in the UAB EMR are geocoded and then linked to census tracts. So we're able to look at area level data with these individuals. So just briefly, our approach, first, we're going to look at associations between insulin resistance, social determinants of health, and poor COVID-19 outcomes. This will be a cross-sectional look at the data. And then we're going to use longitudinal data. So we're going to look at time to event to assess the independent contributions for insulin resistance and social determinants of health individually. And then we'll move forward in looking at the interactions of insulin resistance and social determinants of health on poor COVID outcomes. So as I harken back to the title of this talk, so a tale of two data sets, there's two sets of data that you sort of have to look at it, the way I conceptualize our project. So data set one is the original data that we get from the extraction team that Mike was talking about. So this is what I call sort of the raw data, which is not exactly raw because they've transformed the data to a point. But this is what we received from the extraction team. We received multiple Excel spreadsheets via share file. It was very straightforward, very easy to go in and get this, but I did have a share file set up prior. We received 11 data sheets, one that was cross-sectional in nature, as I mentioned earlier. This is and contains the patients that have a COVID-19 time point. And then we had 10 longitudinal data sets, or if people that deal with data, they're long data sets. So they have multiple encounters from the years of 2017 to 2020. So different data sets that you get, depending on your study. And what I call data set two is the data that we're working on currently. So we have to sort of go in and derive variables and transform the data further to make it ready for our analysis. And so I'm just listing some things that we're working on now or that we've done. So first, you've got to get the data sheets uploaded correctly. We had a little bit of a snafu that was nothing to do with the data, but it's just dealing with data. Right now, we're working on our cross-sectional data for really setting our analytic sample. And I'll talk to you a little bit here in the last bullet point about what we're doing with that. But the next phase is to line up our longitudinal data, which has multiple encounters. And anybody that's dealt with longitudinal data knows that there's caveats that you have to deal with getting that lined up correctly for analytical purposes. As we've been going through this cross-sectional data, we've begun to look at what is sort of missing in the EMR, what's implausible. And so this has nothing to do with the extraction team. It's just the data that's there in the EMR. And so just some things that we're running across right now in this phase is that we're finding people that have birth dates that are not feasible. So somebody has a birth date of 2028. Now, when we go back and look at the data, we're pretty sure this is somebody that was born in 1928. This is a keystroke error, but I'm just pointing this out that these are the types of things that you'll find in this data. We're also finding very implausible BMI values. So you can see here a BMI greater than 200 kg over meter squared is not plausible. And when we go back and look at those height and weight variables, it looks like there's keystroke errors there as well. And so this is just inherent in the data. And so we're going through and vetting this data and really cleaning it and really trying to understand, what we may have to go pull further, doing record abstraction, and what we may have to just say, this is implausible and we can't use this data. So I was asked to present some very preliminary data. Now, this is hot off the presses as of Friday, thanks to Lee Zhang. I think she is on this call. She is an analyst that's working on this data. So this is due to a lot of her hard efforts in a very short amount of time. I do want to throw the caveats. This is preliminary. And so we're still vetting and cleaning the data. So these numbers will change, but I wanted to have something to sort of show you what the data is looking at in terms of our project. So when we're looking at that cross-sectional data, it looks like we have roughly 11,000 in our unique individuals that have a positive PCR in the UAB health system. And we have individuals that, of those individuals, they are a mean age of roughly 50 years old, predominantly female. And then for COVID-19 outcomes, it looks like 32% have had a hospitalization, 12% have been admitted to the ICU, and a little under 5% have had a death during hospitalization. And then we see here on the right the distribution by race and ethnicity. So we have roughly half are white and about 40% that are African American. Again, preliminary as well, so take this as you will. But here are poor COVID-19 outcomes by race and ethnicity. Here you see on the left for hospitalizations and for ICU stays, we do have elevated proportions among the minority groups compared to whites, and then a little bit of a mixed bag here with death. Again, preliminary. Again, here we have poor COVID-19 outcomes by comorbidity status. On the left, we have individuals in the dark green are individuals with obesity, so a BMI greater than 30 kg over meter squared. Those in the light green are those without obesity, so very similar, at least at this portion, very similar proportions here in terms of poor outcomes. And then on the right, we have individuals with type 2 diabetes. So in the dark green, type 2 diabetes, light green, those individuals without diabetes. And we're seeing sort of this emerging higher proportion of poor outcomes among those with type 2 diabetes. And this is not surprising. We're starting to see this in the literature. Again, very preliminary, so take it as you will. And we hope to get to dig more in this data in the coming weeks. So I was asked a little bit to talk about the successes and challenges I've had going through this process. And so first I'll start with the successes. I think it's just wonderful that we can leverage existing data that is in the electronic medical record, and also get our hands on some longitudinal data, which is some people know is sort of hard to come by. As Mike said, it is a comprehensive data team. It is excellent to be, I want to say in the room, but it's really on a Zoom phone call with individuals that are data experts, that are statistical experts, that are outcome experts, that are bioinformatics experts. And so really being able to go to a one-stop shop in some of those meetings instead of saying, hey, I have to reach out to somebody else and send an email. You really get a lot of that synergy and questions answered in that one meeting. It is a straightforward process that is helpful. And so you just go, you could go today and fill out a form for your concept proposal, and then you get into that pipeline. And then, of course, the major success is we have data. We have data to be able to answer these research questions that we have, and that's a success in and of itself. In terms of challenges, we did have a long wait, but that's understandable. As Mike said, this is, was made in real time with people that have other hats that they wear. And so it was understandable. And we also requested longitudinal data, which brings in some other additional caveats there. As I mentioned earlier, missing data, but this is inevitable with any electronic medical record. I've had a little bit of experience at another institution, and we had some of the same issues of BMI being out of range and keystroke errors. We had a discussion that came up about some of the census tract data, and what's really great about this is that Gabriella Oates on campus has spearheaded a social informatics initiative about capturing social determinants of health data in the electronic medical record. And so I've been involved in that. Mike came to that meeting last week, and so we're really learning how we can really use this data and capture it in a systematic way, which is great. And so overall, just on takeaways, I think that this is really great data that can inform us specifically about our UAB population. It really gives us opportunities for precision public health. For those of you who are not familiar with that phrase, that is delivering the right intervention at the right time to the right population. I believe it's a rich resource. And just like anything, if we don't use it, we may lose it. So we have to use these projects to really justify being able to come and use this. And if anything you take away, just I hope you take from me, is EMR data is inherently messy, but projects like this will inform initiatives to improve, right? So I have here on the right a initiative at Vanderbilt University where they were able to go in and really reduce the transcription errors in BMI. So we don't really know how to improve it unless we use it and know that it's there. And then just to wrap up on the play that I have on the title is actually a play on Charles Dickens' A Tale of Two Cities. And so I just have to say at the end, it was the best of data and the worst of data. And here is the quote that starts that famous book. And in the end, I'd like to acknowledge my research team, Tim Garvey, and his use of the CMDS, and introducing me to that. Ning-Jun Yi, Andrea Charrington, and Li Zhang, who's on the call and has really moved some mountains to get this data today. And of course, the UAB COVID-19 core team. So thank you very much.
Great. Thank you very much, Carrie. That was a great presentation and a great example of how you were able to use the resources available at the COVID Core. Next up, we have Yulia. My screen just went wonky. Yulia Khodneva, who is going to talk about her project. And again, we'll hold for questions until after Katherine has spoken. Okay. All right. Ready to go. It's all yours, Yulia.
Can you hear me okay now? Wonderful. So I'm going to switch gears a little bit, and I'm going to talk about our project that was investigated the clinical outcomes of COVID-19 infection in a racially diverse sample, and specifically looked on the role of the Renin-Angiotensin-Aldosterone system inhibitors. So it's a very complicated chemical name of actually two groups of medicines that we know very well that treat hypertension. It's ACE inhibitors and angiotensin receptor blockers. So let me give you just a very quick background of this study. So why you think would these two classes of the antihypertensive medicines and COVID-19 have in common? So it turned to be that first, in the animal studies, it has been shown that COVID-19 virus and those two classes of drugs work through the same pathophysiological mechanisms, and specifically COVID-19 virus binds to angiotensin converting enzyme 2 receptors that are placed in the lungs. So as I talk, I'm going to put the dates on all this process because I think it's very important. So in February and March of 2020, so there started to appear reports from China, mainly raising some concerns of usage of these two antihypertensive class of medicines in patients with the COVID-19 because some of these reports showed worse outcomes. In March and April 2020, there were also reports started to show from Italy, United States, mostly from the West Coast of the United States and China, that showed increased mortality from COVID-19 in patients with hypertension. So at that time, it was really unclear what was going on with the virus. Is the hypertension itself is a risk factor, or the medicines that patients were on it presents a risk factor. So the objective of the study was to examine the association of the pre-hospitalization use of RAS inhibitors and COVID-19 outcomes in the cohort study of UAB patients. And the other thing, the very important reasons for this study was actually sort of grassroots coming from the community, from both patients and physicians. So a lot of patients, and me as a primary care provider that I'm dealing with hypertension, asking me questions whether they actually can take those medicines at that time, March, April 2020. In case of the contract COVID-19, what the outcomes would be. At the same time, in the community with the primary care physicians, there was also a question whether these patients should be continuing these medicines or not. There's a lot of, there's a big call from the community and a lot of unanswered questions. So this prompted us to create a proposal in the April 2020 in the answer to the RFA that was posted by UAB School of Medicine called Precision Institute that announced about in the middle of April a call for the scientific proposals. And the main criteria for those proposals were that it should be done quite quickly and should produce some summarizable and meaningful results in 6 months. So we prepared this proposal and applied, and we received this funding in the April 2020. The project was Irb approved in May 2020, and at that time I started to collaborate with the core COVID-19. So in terms of our method, so the main task of this project was to create a cohort study using existing electronic medical records. So Dr. Mugavero and Carrie Howell describe this process in the detail beautifully, but I would like to emphasize this a little bit again, because some of us have experiences working with the cohort studies and doing analysis. And as you probably know, so there is a lot of thoughts coming into the creation of cohort before the actual cohort is created. A good example is cardiac study or regard study, where scientists think about the questions they're trying to answer with the cohort study. It's a big enterprise. So they think about all the measures, what tools they would like to incorporate, what the outcomes will be, and how they measure these two things, exposures and the outcomes. And this all done beforehand and have a really good time to think through and have very accurate measurements. So we actually did not have this time in hand because we were dealing with the pandemic. And so the way how I, would like to describe a creation of cohort study in a way of this diagram, that the first, that we have a concept. So we wanted to look on the clinical outcomes of COVID. We wanted to look on the specific medication use. The second thing that was coming after the concept is this data elements in the AHR, electronic health records. And the final results that should be analyzable measure that we can use as a scientist in our final data set to answer our question. So by the same talking, so we started to look on the study participants and think about what our cohort of the study participants would be. So the idea, the concept behind the study participants were the patients hospitalized with the COVID-19. That's what we know. So when we were talking about on our gateway meeting, what that would be in terms of the EHR elements. So it was all inpatient encounters with patients who had positive PCR since March 1st, 2020 at UAB hospital. So this has actually entailed multiple data points for each of the participants that as a result has to be coming into the main data set that would have a cohort of records, one record per person. And as a result, we assembled a cohort of 1,024 inpatients with the COVID-19 PCR-approved infection from March 1st to September 16, 2020. So that was our analytical data set that we got. So in terms of the measures, so the same thing went through the measures. And a good example that Carrie actually highlighted already very well was obesity. So this is the concept. We wanted obesity to have among our measures. So the EHR data included height and weight plus minus 30 days from the first COVID positive test. So we wanted to have those measures as close as possible to the earliest COVID test because some of the patients in UAB actually had several COVID tests, and it was important to find the first date of the COVID-19 positivity. And then the way already described that, so we went through data extraction and transformation in May 2020. So I submitted my proposal to the team and they looked ahead of time. And then we had our data gateway meeting in June. Then based on this meeting, the complete data set was created in the end of September 2020. So after looking for the several data sets that we have, Carrie already explained that because we had a main sort of the master data set for the cross-sectional measures at the time when the COVID was diagnosed. And then we also have longitudinal sets for additional visits, including inpatients, hospitalization, and readmissions. So we sort of were back and forth asking for clarifications, sending additional data requests. And that was happening in October 2020. And we also did additional manual data checks, especially for the dates and for deaths. And that was done in November 2020. And I'm specifically putting the dates here because you can see that actually, so some of these things were done also quickly, but it also took time to produce a quality report. So the clinical outcomes that we focused on the study was in-hospital mortality, respiratory failure requiring invasive mechanical ventilation or intubation, and also same hospital 90-day readmissions for any cause. So in terms of covariates, so we were looking on the previous reports, and again, so back to the creation of the cohort study. So this is not pre-specified, so we have to look into the data as it was actually emerging. So I was literally April, May, in June on the JAMA website, on Lancet, on most of the important medical journals, because there were reports coming in, case studies and case series talking about the potential covariates for similar studies. And then finally, CDC has published the report telling us what things have to be and what things are important for the COVID-19 outcomes. And it turned to be, so we included the main demographics, and we included pre-existing comorbidities such as coronary artery disease, hypertension, heart failure, obesity, BMI and obesity, diabetes, COPD, HIV, patients with the transplants, and smoking status. So let me show you some results from the study. So let me just do it a little bit different. So participants, unfortunately, are closing my study here. Okay, so this is just the baseline characteristics of those patients that were included. The median length of stay was 7 days with the interquartile range of 4 to 15, but we saw some so-called long haulers who were actually hospitalized up to 170 days. Interestingly enough, so this sample, about 2/3 of the sample was admitted between July 15th and September 16th. So this is sort of corresponding to the how naturally the pandemic unfolded in Alabama, when we didn't have this big spike of cases like New York or the West Coast experienced, and our cases started to slowly rise after July the 4th. So the mean age of the sample, this is inpatients again, and this is just this 1,000 people that we looked at, was 57 years old, pretty young actually. So 52% were African American. About 48% had obesity. And there was a pretty large number of the other comorbidities such as hypertension, coronary artery disease, 20% diabetes, and we had very high number for heart failure patients at 31 and 31% chronic kidney disease. So this slide just displays our main results. So this is the RAS inhibitor use associated with the in-hospital mortality. And those graphs that you see display the adjusted hazard ratio and the 95% confidence interval. So first we'll look on the overall sample, and this is also adjusted for all the covariates that I mentioned. So it seems like patients who were taking those medicines before hospitalizations were 0.05 as likely to die from COVID-19 compared to those who did not take those medicines before hospitalization. So this is represent about 40% reduction in mortality and was statistically significant. So in the ideal situation, we would use things such as, for example, propensity score matching, if you're looking on the medication use and some clinical outcomes. But not, for this study, we didn't do that. The other way to control for confounding by indication was to look on the patients who have indication for ACE/ARBs, which is also includes heart failure, chronic kidney disease, coronary artery disease. So that's what we hear, and hypertension. And then we just look on the patients with hypertension, and the results, as you can see, were pretty similar. So overall, I should say, in this sample, that this 1,000 people, the overall in-hospital mortality was 13.4%. So this is different from what Carrie just presented, because it's a much smaller sample than hers, and this is the beginning of pandemic. So that's why it's maybe different from her data. And another factors here in these models were associated with the increased mortality risk were age, obesity, and heart failure. So in terms of the other outcomes, so I'm just going to highlight the most important findings. We have much more in the paper, but among patients with hypertension, baseline use of RAS inhibitors were associated with the reduced risk of respiratory failure or invasive mechanical ventilation. So the important thing here was also that we controlled for differences in the treatment approaches to COVID-19 patients who were hospitalized. What I mean here is that, again, so we were just doing this in the real life, urgently. And in the beginning, the guidelines were actually to go ahead and intubate patients as soon as possible. But those guidelines changed throughout the time, sometime mid in summer, to delayed intubation strategy. That meant that patients were placed on a different oxygen delivery mode, which is called high flow nasal cannula oxygen delivery, and they actually showed better outcomes than intubation. So that's why this analysis has to be controlled for the timing of the hospitalization. Another thing that we looked at is in the same hospital readmissions. So in general, about 19% of the surviving patients were readmitted to UAB. It's pretty high percent. It's actually higher than another studies that are published right now. Just one study that's showing same thing. And we found no association of the RAS inhibitor use and same hospital readmissions. Another important thing, again, sort of a little bit corresponding to what Carrie was saying, the patients with diabetes had actually a 1.5-fold increased risk of the same hospital readmissions, and I think it was very important. So let's talk a little bit about the limitations of this study. So it's definitely a single hospital site. It's observational design. So it's a, electronic medical records, or electronic hospital records have some inheriting limitations just embedded in that. One example, for example, is that we were looking specifically on the comorbidities of COVID-19, and it's important then we understand that this data may be incomplete because it's human factor. So it's basically a physician or a nurse has to chart those comorbidities. Otherwise, we would never have them on file and we would never know. Another example is missing data. We also had some missing data, and for example, in the smoking status was about 11% missing data, or 125 patients did not have smoking status on file in the records. So we had to include a special category for these patients to preserve the sample. And another limitation is that data on readmissions and deaths were limited to UAB hospital data. But we know that in the area, there's more, hospital facilities. Patients can be readmitted to different hospitals. They're also out of hospital deaths that we, included in some of our analysis, but we understand that this is actually not a complete data. So in conclusion, RAS inhibitor use was associated with a lower mortality. In patients with hypertension, RAS inhibitors were associated with a lower risk of mechanical ventilation. And there was no association with their readmissions to the same hospital during the 90 days. And I just want to acknowledge a lot of people. So mainly my primary mentor, Dr. Sherrington, Dr. Suzanne Oberil, who's on this call, my co-authors, so Dr. Stephen Clarkson, who did a lot of manual checks for data, Dr. Gargi Amala, who did a lot of data management to make sure that the data sets, again, many data sets we received from the COVID core, we were able to analyze, and Dr. Wheeler, who was a really driving force for us and helped us tremendously to get the data on time. All the people who helped with the data precisely, UAB Informatic Institute and the whole COVID-19 core. And my funding for this project from the School of Medicine, the specific funding mechanism, and my two T32 grants that I was during this. And just to kind of finalize my talk, I just want to mention that to me it was a tremendous learning experience. Also working pretty independently during the pandemic time. So it's corresponded to the times when we started to work remotely. There was a lot of challenges. There's a new infection. There was a lot of mental challenges in terms of finding time for everything, work and life balance, and doing a new research, completely unknown, uncharted territory. And I think it was just tremendous experience, of learning how to lead the project, meeting people, communicating with people in a completely new environment. And thank you everybody for this help here.
Okay, thank you very much, Yulia. I'm going to sort of rapidly transition to Katherine Meese, who has a very different type of project. She did primary data collection. I know we have about 10 minutes left to go, but if people want to stay on a little past 1, that's fine. So Katherine You're up, Dr. Meese.
All right, thank you. Well, I will rapidly talk about our rapid data collection with our new core team during COVID-19. So our experience was a little bit different in that we were actually designing our own study and doing primary data collection in the middle of a pandemic pressure cooker. So we had a great outcome and lots of lessons learned, which I look forward to sharing. So because we're here to talk about the learning health system, I want to talk a little bit about the learning mechanism, or the listening mechanism, and our role as researchers. So when I joined the UAB Medicine Office of Wellness at the beginning of this year, along with becoming a new faculty member, my aim was to focus on rigorous scholarship that can serve the dual purposes of informing the organization, helping give leaders real tangible information that they can use to make changes, helping senior leadership listen to the organization, but also generating good scholarship. And so everything that we do arises from needs that are perceived within the health system. And we walk the delicate balance of trying to meet both the needs of operations and scholarship. And so, for example, in a large health system like UAB, often the voices from the front lines get filtered through the manager, who gets filtered through the director, who gets filtered through the vice president, and on up it goes. And so sometimes it's difficult for our leaders to really get a true picture of what's going on the ground. And so we wanted to bring clarity in that situation and offer an opportunity to more freely move information through the organization. So with that, because we have sort of these dual aims around operations and research, we want to create information that's useful for leaders, but we also want to have rigorous scholarly output. There are certainly some competing demands. So while these things can inform each other, they also are at times at odds. So for example, on the operations side, to use validated mechanisms that are most likely to result in the best possible publication, we need lots of questions. Okay, so these validated tools are usually 15, 20 questions. At best, you might get one with 10 questions. So we were very quickly told by our operations counterparts that there's no way you're sending out a survey with more than 10 questions, because people are not going to take it, they're going to glaze over. And so we had to balance the need of what makes sense for the organization. We don't want to add an additional burden to people, but what can we also use in as rigorous way as possible? Maybe it's not the best validated tool, but can we find shorter single item measures, et cetera, that have been used in research, prior research? The other thing is that sometimes the operational needs and the scholarly needs don't perfectly align. And so, for example, we had a lot of interest in collecting quick data around telehealth and how the implementation of outpatient and inpatient telehealth was going. So we worked very closely with Eric, who is over all of UAB e-medicine, and making sure that he was going to get the input he needed to make real change quickly as he did this rapid implementation. But because we were trying to keep the survey short, we didn't necessarily get to ask all the questions that we would have asked were we specifically implementing a telemedicine study. Additionally, on the research side, we have to be cautious that there is some sensitive information within the organization, and that we need time to share that information with the right leaders and the right people within the organization before we share it with the world more broadly. So we certainly didn't want to catch anyone off guard and had to think through some of those political considerations. So I was very fortunate that as I was thinking through my research plan for the year, COVID hit, and yet at the same time, there was also this great mechanism to connect with other people that were interested in doing healthcare worker well-being research. And so on a call, I think that Mike and Allison were on, and I remember Dr. Tony Jones, we mentioned this idea of starting a core scientific working group around healthcare worker well-being. And much to my satisfaction, Greer Burkholder and Patricia Patrician had also already mentioned an interest in such a group. And so what you see here is this truly interdisciplinary group that we were able to form with representation from medicine, nurses, health services administration, sociology, industrial organizational psychology from Auburn, and our APPs. And so what this allowed us to do, fortunately, was to very quickly get feedback for the range of people that we were studying. So our study was targeted at physicians, nurses, APPs, and administrators. And so we could get very quick feedback from people who actually sat in those positions on how we should be asking certain questions. I will also say that one of the beautiful things about this group is how tremendously diverse it is, not only from an interprofessional perspective, but also almost every race and ethnicity is represented in this group. And so as we started thinking around questions involving responses to some of the issues that we were having around societal and structural racism last summer, and the racial tensions that we were experiencing in our community, and even how race was impacting people's well-being during COVID-19, we had this wonderfully diverse panel who could help the group think through how we would delicately ask questions, how we can word things the right way, and what nuances we might be missing out. And that's certainly a perspective that I could not have brought with my own lived experience. And so I'm very grateful for the diversity of this team. So we wanted to look especially at healthcare worker well-being during COVID-19. And so as I started looking for baseline data before COVID-19, the good news, bad news is that it isn't there. Okay, so we have some statistics from these various groups that were captured before COVID-19, but they all use different instruments, some which were validated, some were not. There were no controls for organizational dimensions, and pretty much no one's looking at clinical support staff or ancillary staff. And so we wanted to understand the entire team within one organization so that we reduce some of the interorganizational noise. And we also wanted to use the same validated measure to really understand what is the range of experiences that are happening across these groups. Fortunately, the organization had already captured baseline data using the Wellbeing Index out of the UAB Medicine Office of Wellness. And so this was another great boost for us as we were standing in between the health system and the research enterprise, being able to use operational data that had been collected, not for research purposes necessarily, to help us get a feel for what the changes were during COVID-19. And on a scale of -2 to 9, 9 indicating high distress, and any score at or above 2 indicating high distress in the general population, we had substantial increases across all groups within the organization. And interestingly, as you can see, this green dotted line is the threshold for high distress. Everybody, every single group is at risk for high distress during the early phases of COVID-19. And so we wanted to bring this information to light so that people could really have an understanding of it's not just you, it's the person to your left and right, up and down, who are experiencing distress, and to bring light to the fact that people really needed to be taking care of one another and that we needed to address some of these issues with our employees rapidly. I won't go into detail here, but essentially what you can see in the percentages is the percentage of that employee group that was considered high distress compared to the general population. And this is not just, oh, they were really stressed out. I mean, this is 2.9-fold higher risk of burnout, 2-fold higher risk of suicidal ideation, higher risk of severe fatigue, patient error, et cetera. So 75% of our administrative and non-clinical employees, 89% of APPs, 92% of clinical staff, which nobody is studying, 90% of nurses, and 71% of physicians. So this really helped our leaders understand how dire this situation was, and that it's really across the board, because historically in well-being research, it is focused only on physicians or only on nurses in isolation. In addition to the operational data that we had already collected using the Wellbeing Index, that data really isn't usable for research because we don't have access to the raw data per the vendor. So with this data that we were able to collect as a team, we actually were able to understand what are the things that are driving that distress, and what are the levers that our leaders could push and pull to make an impact. And so what we found is that many of the top 6 things that were driving those higher distress scores were all work related. And those are all things that are within the realm of issues that can be somewhat addressed. It doesn't mean that it's easy, but heavy workload and long hours, increased job demands and responsibilities, and moral distress, perceived support of the organization, and autonomy in one's job. So these are all areas that now we can target and try to make changes in order to impact our employees. This data resulted in a publication that's been accepted, and it's currently in press in the Journal of Healthcare Management. And it also represents the largest study within a single health system in North America of healthcare workers. So we have the largest one to date. We'll see if that continues. But the second largest study had 37 authors. So I feel like our small but mighty team did pretty good on this one. So in terms of lessons learned, what went well, the survey development was much more rapid, having access to the core group. There were 2 people in the core, Greer and Crystal, who had already piloted and distributed a survey nationally. And so we were able to take lessons learned from those surveys and roll it into this one. We got much faster IRB approval. Jazz Singh, who's in our group, already had IRB to survey the employee population. So we were able to submit a quick amendment and get approval to disseminate that quickly. And then we were able to rapidly get input from key stakeholders. So we were able to get input from nursing leadership, from leadership of our APPs about what they would like to see operationally, and also from members of the group. In terms of challenges, we certainly had different professional norms that we had to navigate, and this is among a group of strangers who did not previously know each other. So for example, in my discipline, it's unusual to have more than 5 authors on a paper, and in medicine, having 30 is not a big deal. And so just working through some of those types of differences. And then also, of course, competing demands. We're all doing this on the side as an addendum to our full-time jobs. And so our paces and our ability to contribute were different. And then we all had varying research interests and goals. So we weren't all moving in the same direction when we got together. We were just under the same umbrella. And so trying to make sure that we were incorporating varied interests, but also able to move forward in a timely fashion. And then the last thing I'll say is that it's doing real-time organizational research in a pandemic pressure cooker when the entire world is trying to publish on this topic is messy. But having very good people by your side who are passionate and committed certainly made it worth it and made it bearable. And so we have several papers forthcoming and in various stages of development. And I'm grateful for this experience. Thank you.
Thank you, Katherine. You spoke rapidly on your rapid implementation of a survey, so thank you very much. I know it's 1 o'clock. I'd hope that there would have been some time for a panel discussion, but if there's anybody with a burning question or comment, I think these are all really good examples of the potential for our learning health system over time, either primary data collection or going to the EHR. Are there any sort of quick questions, thoughts, comments, reactions before we sign off? All right, everybody, I won't keep you with my own boring question, but thank you again for attending. We love the turnout, and stay tuned for our final session next week, which will be a compilation of what we're hearing across the enterprise with what we think the UAB's LHS system ought to look like. So stay tuned for that announcement, and thanks again, everybody.